Aloha, Hawaii. It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Hey, we're very, very happy to have you again with us. If this is your first time, Vein Clinics of Hawaii are truly of Hawaii. They're Maui, the Big Island, Kauai, and here on Oahu. Dr. Juliff is the medical director and proprietor, and pretty up to speed on Hawaii. And one of the reasons I guess that we here in Hawaii are a really great place to be a medical professional is of our ethnicities, our 24/7 and 365 lifestyle outside, all of the good things, but also some of the things we eat and some of the other things we do are not so good. So today we're going to talk about venous insufficiency. And what that is actually varicose vein issues. But you're going to become an expert in this because Dr. Juliff has got the plan. And we're going to talk about what the disease is really. And then we're going to talk about, what kind of folks get it. And then we're going to talk about today the traditionally acceptable way to treat vein disease, and one of the new ways, and then in the subsequent program, two more. In other words, there's a lot of stuff happening in this profession, and even though that was kind of a lengthy introduction, Dr. Juliff, I think that because this disease is a disease that really doesn't come on in a traumatic way, boom, here you got a broken leg or a broken arm. This thing sneaks up on you for a long period of time, and I guess sometimes by the time people either seek or need care, if we'd only started sooner, might have been the answer. Is that right?
Yeah, that is the case.
By the way, I could see you like raring at the bit to get going because that was like way too long of an introduction. I'll work on that.
I was going to go out for lunch.
Yeah, no kidding. Bring me back a sandwich. I'm just getting warmed up. But seriously, I think that what we're learning here is what we've done in previous shows, and I'm just made the rash assumption in the beginning that it must be actually really neat and challenging in many ways when you're working with so many different kinds of people in a practice.
Yeah. Well, two things about vein disease is that, number one, it's so common. 50% of adults, essentially, by the time they're 50 years old, roughly, have some amount of significant venous insufficiency. So, essentially every other person walking down the sidewalk has vein problems. Number one. Number two, you mentioned Hawaii, and you're right. I think there's even a little more amongst the general population of Hawaii. There's a lot of vein disease. And it's probably a little genetic because venous insufficiency is definitely a genetically predisposed sort of situation or problem that people have, and also the lifestyle. You mentioned people. People in Hawaii, they're very active. They're out there, 365 days of the year doing stuff, and a lot of or various activities can sort of push the process along.
I got to tell you that I've talked to a lot of people since we started the show. And they say, why don't you guys talk about more dietary things like dietary decisions that can change my venous condition? And, I tried that when we first started. And it doesn't, it's good to be on some sort of a regimen anyway with your food intake. But I'm not sure that we can blame a diet as the culprit in this.
Yeah, we can't.
Yeah, it's very interesting.
It's very much the opposite of arterial disease. Mm-hmm. When we think about arterial disease, we think about smoking, diabetes, cholesterol, weight control, all those things that you can actually do something about, have an impact on your lifestyle, and you sort of change the evolution or the progression of the disease. Yeah. Unfortunately, not so with venous disease. Yeah. You're sort of, if your parents had it, you probably are going to get it. And it doesn't matter how much healthy food you eat. We get that question all the time.
I'm guessing that is because by the time people have manifested or identified a venous disease, they're just old enough that they have other things that they've been doing wrong for a while, whether it's diet or whatever, so that you can't think you start fixing one thing and everything's going to get fixed.
Yeah. So when we ask that question, who gets venous disease? Probably the highest risk category are those people who have parents and they have that genetic.
Thanks, Mom. In my case, yeah.
Exactly. If one parent has it, the likelihood that you'll have it is up around 60. If both parents have it, the likelihood that you will develop venous insufficiency to one extent or another is about 90%.
Okay, now if you so happen to get hooked up with a partner, a guy meets a gal, and they're both from families that have that issue. Now we're both bringing way too much venous disease to the party. So that's why I've asked in previous shows, and generally speaking, even though this takes an awful long time to manifest, it's not as though it doesn't ever appear in younger kids, because it does sometimes.
Oh, it does, yeah. We have treated a good number of teenagers.
Yeah.
I think the youngest patient we ever had was about 16. And of course, they had very, very strong family history, and substantial disease. And interestingly enough, two of the younger kids that we have treated recently are both boys. The other fallacy about venous disease is that it's women who get it. Now, women do get it a little more frequently than men, but men get it all the time too. And as a matter of fact, the worst varicose veins that I have seen in people, over the years, most of them are men.
Yeah, it's here's the deal, and I, as a patient, I know that men are a little bit, they're more vain. They're maybe not as conscientious. Maybe they don't look at the back of their legs like women do. But it still is, I guess, just as much of an issue if it goes unchecked that something's going to happen. And I'm also wondering, if we see on television at night now all these new medications for all these things, and the words or the expression of DVT comes up a lot, and oh yeah, I had a DVT, that's what made me start this or that thing. Has it helped in some respects the attention that DVTs have been getting as to just venous health in general? If I've got DVT, maybe I better get looked at.
Yeah, I think.
Or do I have DVT?
Well, I think so. Yeah, because DVT is something also that can strike just about anyone.
And you can't see it, can you?
No, you don't know exactly what's happening initially. But interesting. Well, yeah, all the media coverage of DVT over the past, let's say 10 years or so, has been good, because there are many unnecessary deaths from DVT, DVT and lung blood clot. That didn't really have to happen if people recognized what was going on, or if they knew that they were putting themselves into a situation that was going to put them at high risk for developing a DVT. So that's why, on every airplane anymore, you open the magazine and they've got the exercises.
It's in there. And I like that.
And I think that's good.
Yeah.
That's great.
And by the way, because a lot of us listening to the program, first of all, age knows no boundaries. We are a lot younger in many respects than our parents or their parents were. So we're traveling, we're living longer. I don't know if that's going to continue, because I know the current generation is kind of challenged about whether that's going to keep happening. But it's safe to assume that in almost everybody's life, particularly when you start talking about your partners and everything, that one or more of you are going to have that condition sooner or later. So maybe this attention to DVT says, I don't know if I have that, but I've never had this ultrasound. I don't know what that stuff is. Why don't I look? Maybe I'll talk to my GP the next time I'm in for a physical and say, can you help me out here? Should I go see a vein guy or gal?
Well, and that's a good question, because the DVT is something, as I mentioned, that could strike anybody given the right situation. But those people with venous insufficiency, just in general, are at a little higher risk to develop DVT, especially if they put themselves into scenarios where they are at higher risk, like a long airplane ride, long car ride. People who go into the hospital, and they're all of a sudden they're laying in bed every day because they don't feel like they should get up. All of those people are at a much higher risk to develop DVT. And as time has gone by, and again, especially over the past 10 years, we've taken many, many precautions, especially in the hospital, to give those patients prophylactic medications so they don't get a DVT.
Yeah, and by the way, my friends, let's call her Delilah, a lady that I know. Well, that's because her name is Delilah. She said, I listened to the program, and I was actually surprised to hear this discussion about DVTs because she was told some time ago by a primary care physician when she went in for some sort of examination that she had signs of some issues in her veins, and she had some tests done, ultrasound like you talk about, and the actual doctor, this was 10 years ago, said you shouldn't go to Europe right now. This is not advisable. You need to get some treatment before you can start logging thousands and thousands and thousands of air miles where you're being stationary. Mm-hmm. Pretty good advice. You have to do that sometimes.
Well, that's very good advice. Yeah, she probably had some indication of vein disease underlying, and that physician recognized the fact that she was at a much higher risk category for developing a DVT on a long plane ride.
When you are doing, and we can get into this later when we talk about treatments, which we're going to talk about this show and then a corresponding show. We're going to talk about the common acceptable treatments of the past and what everybody knows what mom or dad or grandma or grandpa had, and some of the new ones. And there are some serious major changes in that. So I'm guessing that you're right. The physician probably noticed something. Is something, if you get referred to, you have venous condition. Your doctor says you've got some varicose veins. You better go see a specialist. Here comes the guy to your office. During the normal course of initial treatment or initial, I guess, diagnosing, do you look for things like DVTs or do you look way inside?
Oh, yeah. Yeah, everybody that comes in and gets an ultrasound in our office looking at venous function, the other thing that we look at is for DVT. And usually when people are coming in on a very elective basis, it's rare for them to come in with a DVT. However, it does happen. Yeah. Periodically we see a DVT where we didn't expect it. But, and which brings up another point, and that is that one of the other kind of misconceptions, I think, that we have to deal with all the time is people who have symptoms of venous insufficiency that are not necessarily varicose veins.
Okay.
Varicose veins are easy. Mm-hmm. I mean, everybody knows. Most people out there know, gee, I have varicose veins. I must have a vein problem. But not everyone with venous insufficiency necessarily has varicose veins. So we have to think about the other symptoms. People typically have heaviness, fatigue, muscle cramping, achiness.
Start writing these things down, folks, because we all got some of them. We just got to make sure, are they connected?
Yes, yeah. And swelling, something called restless leg syndrome. All of those are symptoms of venous insufficiency that may not include varicose veins.
Yeah, this is so interesting. And there's another thing. We've talked about our previous programs. We'll only designate a couple of seconds to it here. But a lot of people, men and women, but a lot of times young gals, they get concerned about these spider veins. So they come to doc all the time, get that treated. And there are a lot of people that assume, okay, well, if I got spider veins, I must have varicose veins somewhere. But you said, it's quite probable, but not necessarily automatic.
Yeah. Spider veins are a little different in that spider veins may or may not be a superficial sign of important venous insufficiency. So, and typically when people come in with spider veins, unless they just have absolutely no symptoms whatsoever, usually we check those people with an ultrasound and make sure that they don't have underlying vein disease that is something that should be addressed. But much of the time they don't, and we can treat spider veins pretty easily and not get into a lot of complicated.
Yeah, and we'll talk about that real briefly. But basically, I think it was a very big value to me when Doc and I first started talking about this program. I remember my mom, who was a very hardworking lady, and I can thank her. May she rest in peace, for my varicose veins, but it was exasperated because she worked on her feet. She was in the retail business forever and ever, and she was a model, had lots and lots and lots of work done. And as I remember, and I was talking to my brother and one of my sisters about this, who know that we do the show together. And, my sister said, I remember Mom was down for like a long time when she got some of this treatment. I think that some people have that memory of their parents, and so they're reluctant to come and see. They don't want to be in bed for 3 or 4 days.
Yeah. We fight that too because everybody's had either a story of somebody's grandmother or their own grandmother or mother who had the old-fashioned surgical vein stripping, and were in the hospital several days and went home with huge bandages and a lot of bruising and pain, and it took quite a while to get over that. And luckily nowadays we've got some procedures that make it a whole lot easier. And we'll talk about that.
Yeah, and I say now you walk in, you hula out. I mean, it's it is way, way different. Okay, but that being said, and if you go to veinclinicsofhawaii.com, you can see some of this stuff. There's some great videos and some great little things that you can get and watch about what these are. But every single one of them sort of circulates around or sort of embraces these things that you call valves.
Right.
And I saw one illustration that was really important because it showed the valve that was working properly. So the blood was going up through these little gates and not coming back down. And then the other one was fluttering around a little bit. So some blood went up, but some of them turned around and came down again. These are the little things we're looking for.
Yeah, and that is the crux of the problem there.
Yeah.
In our veins, we have numerous one-way valves. Yeah. And the valves are tiny. I mean, when you look at these things in real life, they're just tiny little wisps of tissue. Which is why we can't surgically repair them. That's not how we fix this problem.
Knock on wood, but it's going to be a while.
Yeah, maybe it'll happen one day. But, valves fail. Now, blood in veins should be consistently moving upward because veins take blood back to the heart. So in our legs, the blood should be continuously moving upward. If we have this problem with the valves, or as we develop further problems with the valves as we go through the aging process, as you mentioned, the blood starts to, rather than just moving upward, starts to now settle down into the leg and creates what we call pooling of blood in the lower leg,
which manifests in my case back then in swelling.
And all of those other symptoms
Deadness,
that we mentioned,
pain,
achiness,
tingling, all kinds
heaviness,
of stuff.
Exactly, muscle cramping, restless leg, and then also eventually, or at some point, also then leads to the more superficial things to arise, like varicose veins and spider veins.
Okay, now in the very beginning of the treatment, we mentioned, and we'll go back to it when we need to, but we have some really exciting things to talk about. This show and in a sister show that's going to be also available both on the website and by podcast, and that is some of the newer things, newer procedures, if you will, newer in that I guess the entire venous profession is moving at the speed of light, because weren't these vein stripping methods done for centuries?
A long time.
Yeah.
Long time. And they were done for, many, many years. And up until, about 20 years ago. Yeah. It's really been only about the last 15 years that we've really been able to, utilize these newer devices that have made the treatment of venous insufficiency so much easier.
Yeah, and we'll run through some of the other things that are injected into the legs, some of the things that are, into the veins, and some of the things that go into the veins and do some stuff. But one more question on the vein stripping, because we know that the superficial stuff that you're doing, the cosmetic stuff, the spider veins, that's always done very uninvasive. What about back then? Were spider veins also a big problem to get rid of?
Yeah, you mean back when we were still doing surgical vein stripping? Yeah, I think that spider veins were injected back then. We've got some newer medications these days that work a little better, and medications that don't cause as much burning and discomfort when we use them. But back then, people were getting their spider veins injected.
Okay, the reason why I asked, because I'm thinking of hot sauce. And do you want something that really tastes good, or do you want something like that'll take the paint off the wall? And I'm one of these sensitive guys. So there are some people whose sensitivity levels are different. But I must tell you, the spider veins that I had removed, some of which were very, very old and on there for a long, long time, if I'd have known how easy it was to get rid of them when you got rid of them, I would have done it a long time ago. And I know you hear that all the time.
Yeah. People are different. Some people have more discomfort than others. But by and large, most everyone tolerates, spider vein injection pretty well. And
because it's small, teeny little needles that you hardly even see.
Oh, they're small.
Yeah,
they're small.
Yeah.
Even though the treatment doesn't bring about 100%, removal, we can do a pretty good job with diminishing the overall appearance. That's
okay,
for sure.
so now let's leap forward. It's what I think is fascinating about this, and that is, and I think I've likened Dr. Julius Vein Clinics of Hawaii to our radio studios. I mean, I started in this business over 50 years ago, and the only thing that's in the studio that was when I was there is a microphone. Everything else has changed. I mean, I've got 7 computer monitors in this room. I can't remember when the first one came along. So it must be very exciting because I know that you have been staying on the cutting edge of this, excuse the expression, for a long time. And embracing these other treatments, not only has it meant, less hassles and less pain, but better results.
It does, I think the long-term higher quality results that we get are substantially improved from the way we used to do it. Yeah, there's no question.
We've got 3 different things that we're going to be talking about in this particular show and a half that we're into. We talked about vein stripping, and we can always go back to that. And if you want to hear something on the program, you go to Vein Clinics of Hawaii, go to Contact, you get a little note off, and we will sure handle it for you in a future show. But I want to get you used to some terms. So we talked about vein stripping. Now we're talking about something called Clarivain. Clarivain. That sounds like a lady on a country and western stage. Here comes Clarivain. What's Clarivain?
Well, Clarivain is one of the newer devices, and it's referred to as a non-thermal, non-tumescent.
Not heat.
Yeah, no heat.
Yeah, okay.
And so I think that before we talk about that, we probably need to summarize a little bit how we have been doing it for the most part for the past 10 or 15 years, and that's through thermal devices.
Right.
Devices that use heat. Yeah. So when we treat venous insufficiency, like I mentioned before, the valves that are failing are so tiny that we really can't surgically repair them. So we had to come up with an alternative. Now in the past it was like we ripped the vein right out of the leg.
Yeah.
That was surgical vein stripping.
I hate to hear that, but that's what it was. Come on, Yeah.
But now the thing that we do is that we close down the vein. So we make it just it's non-functional.
Non-functioning vein anymore.
So why do we do that? Well, we do that because of the fact that in the veins, the affected veins that aren't functioning properly, the blood is going in the wrong direction, like we mentioned. If we close that vein down, then that eliminates that abnormal flow, which is the crux of the problem.
But it still has to flow. So
the blood still has to go somewhere.
Yeah.
So, but luckily our body is an amazing thing. And when we close down the veins, our body really just automatically and, essentially instantaneously reroutes the blood that would otherwise be going through that vein into nearby surrounding normal vein.
And friends, I've had this discussion for years about how often can that happen, and we've learned over previous times, and I'm sure Doc can touch on it a little bit here. You might have a lot of varicose veins, and you might treat them all, but that doesn't mean that you're going to not get some more of them. The ones you treated, Doc, they're gone, aren't they?
Yes.
They're not going to come back.
The veins that we treat with the thermal devices or the other newer devices, they are rendered non-functional with a rate of about 95% long term.
Okay.
So we would anticipate that 95% of those treated veins will no longer be functional, which is what we want. So a 95% success rate for any one particular surgical procedure is pretty good.
Absolutely. I mean, let me buy into that stock.
Yeah.
But the good news is that and I'm not talking about whether it's pain or I'm talking more about efficiency. Maybe these new things like the Clarivain that we're going to osmose into here is a way that you can say, well, why would I want to do it that way when this is available?
There are specific situations where that will probably be more beneficial.
So you have options for treatment.
Yeah, exactly. You like any carpenter, you need a whole bunch of tools. Different tools for different things. But so the way that we had been traditionally closing veins is with heat, and the heat devices that we use were primarily two. Either a laser or a catheter that is called a radiofrequency catheter, because we use radiofrequency energy the same way that we would use laser energy. But both of those create heat inside a vein that we are trying to close down.
Is the difference between the two that that one is an actual wire that you put inside a vein? And you must have a way to get it up to wherever the issue is, and then what happens? Well, you heat the end of it.
Yeah, basically the tip of either one of those things. Yeah. The heat is generated at the tip. So when we're using laser, we use an actual laser fiber. It's a tiny little thing that we enter into the vein, and we do that with a couple little maneuvers. But we enter the laser fiber into the vein that we're going to treat, and then we thread that laser fiber all the way up to the top where we want
where the issue is.
Yeah, where the issue is, and where we're going to start the closure of the vein. So, whether it's a radiofrequency catheter, and when I say catheter, I mean just a tiny little tube that also is not much bigger than the laser fiber, but that is also a device that we can thread into the vein all the way up to the top of the vein. Once it's in position, we turn on the device. It creates heat, and it brings about closure of the vein. So we're essentially cauterizing the vein from the inside. Most people have heard that word before, cauterizing.
Yeah, as a matter of fact, that's heat.
Yeah, it is. Yeah.
But what I think is fascinating is you say that there's an entry site, and I'm guessing that everybody knows that there's not just, here's a vein, let's put a wire up in there.
Right.
No, you actually got to find the vein that's 3 feet away from where the issue is, right? And then you go in there, and your little noodle thing gets all the way up there to do its business.
Exactly.
Yeah. See, I'm glad I'm here because I explain this stuff where I can understand it. So the noodle is on the Clarivain, that it's not heat.
Yeah. So with the other devices, it required heat. Now, why? What did we have to do to protect the patient from the heat device?
Too much heat.
Yeah. Well, you have to numb the patient up with a lot of numbing medication. And we call that process that we use in this situation tumescent anesthesia. Okay. And tumescent anesthesia just means that we're injecting a large volume of saline or fluid along with a numbing medication around the vein that we're treating with heat. So that's doing a couple things. It makes the vein collapse down onto the catheter or the laser fiber. It allows for anesthesia for the patient so that it doesn't hurt them, because if we don't do
Number
that,
one concern is your pain.
Would hurt them a lot.
Yeah.
And then also to protect surrounding tissue, because that heat, since it's killing the vein. Normally, we don't like to use that term, but it's destroying the vein. So if it gets too close to other tissue, it can destroy other tissue too. Most notably, skin. If it's too close to the skin, we can burn the skin, and also other surrounding tissues like other blood vessels or nerves.
Does while you're performing one of these procedures in this thing, the Clarivain, what sort of help do you get from your instrumentation or your stuff to see what you're doing as you're doing it?
Well, yeah, when we're doing any of these or any and all of these procedures, you mentioned, we might be entering the vein, a fair distance away from where the main problem is. But yeah, we use the ultrasound machine extensively to identify the areas of concern, identify the anatomy of the vein. And to then use the ultrasound machine to not only enter the vein, but also to position the catheter, because that's very, very important too. We don't want to burn veins that we don't need to.
Yeah, the thing I find fascinating about this is that, one would have thought that, well, you're constantly being x-rayed so that the doc can see inside what's going on. But in fact, the ultrasound is pretty non-invasive. I mean, I'm fascinated how it works, right? It sends a pulse out and it turns it into a picture.
Right, yeah. It's great.
I'm gobsmacked. I don't even know how the thing works. It's amazing.
Yeah, it's like radar on a very small stage. But so there are drawbacks to there's drawbacks to whatever we do. So you have to be concerned about those, pay attention to them, and make sure that you're protecting the patient from whatever it is you're doing. So the newer devices are now a few that we're going to talk to. They're referred to as non-thermal, non-tumescent, which means that they don't use heat, and they also don't require as much. They don't anywhere near as much of the tumescent anesthesia that we need to put in now,
which is another big key, isn't it?
It's a benefit because even though the numbing medication is not terribly painful going in, there's a certain amount of pressure and discomfort, and some people don't like it more than others, and so there are potential drawbacks to having to put all of that in. It's kind of like going to the dentist.
I was going to ask you that because a lot of people can handle different levels of pain. And I know you see that in your practice every day. A dentist friend of mine says the same thing.
Yeah.
Some people, the minute you hear that the drill touches the tooth, the people get, ah!
Right.
And so I'm guessing that there are times when the normal amount of numbing doesn't work.
Sometimes we see that, but when you go to the dentist, you get the injection there. It's when they first start putting it in, it stings a little bit.
Little poke. Oh yeah, right.
But then your jaw goes numb and everything's fine. Mm-hmm. Well, we do the same sort of thing, but we have to cover a much larger area.
A lot of more real estate there.
Yeah,
right?
because we're often numbing the entire side of the leg. So like I said, we may be injecting a tremendous amount of fluid, and that can be that can cause some discomfort. So these newer devices, number one, you don't have to use heat to achieve the goal. And number two, we don't have to use all of that numbing medication that some people don't like.
Okay, now here's what I'm fascinated about. I happen to be, a couple of paragraphs ahead of where we're going here, so I know how to, make the show work for those of you that are out there. And by the way, you can learn a ton of stuff at VeinClinicsOfHawaii.com, VeinClinicsOfHawaii.com, on 4 islands, and you can call even when we're not open. You can call up. We'll contact you right away, schedule an appointment, get yourself diagnosed. But the thing that I'm fascinated about in this Clarivein is that it's just this tool that blows me away because it actually has a little drill or a little thing that rotates. It's like at very high speed. That must mean you don't need heat because you got that. What is that?
Right. That's a wire that is in the middle of this catheter. Now, again, this device, Clarivein, is a catheter-based device, which means that basically the functional part of it is a tiny little long tube that we thread into the vein, just like the other things that we've already talked about. But Clarivein is referred to as a MOCA device, M-O-C-A.
M-O-C-A.
And M-O-C-A stands for Mechanical Occlusion Chemical Assisted. So there's two things going on there. The mechanical occlusive part of it, has to do with this little wire that once we get the catheter into position and in place for the area of the vein that we want to treat, a little wire can then be extended out through the end of the catheter. That little wire has sort of a hockey stick angle to it.
I was going to say, this is the thing that fascinated me. Because I know that in your mind's eye, because this is radio rather than television or video, you're looking at this big thing. When he says hockey stick, you immediately think of a hockey stick. This thing, you'd have to believe him because you can't see it.
It's very small.
It's very small, right?
Very small, yeah. It's just a little wire.
Yeah.
And it's got, a little, the end of it is a little circular sort of thing, but that gets extended out into the vein, and we spin it. So that device will spin that wire inside the vein, and it spins pretty quick. It's about 2,000 RPMs, so it's going fast. Now, what does the wire do? Well, the wire basically just roughs up the inside of the vein. It's destroying the inner lining, something that we call the endothelium. It's disrupting the endothelium of the inside of the vein, and that is going to assist in ultimately leading the vein to close down.
When that happens, and you've successfully closed down this vein in my leg, do you tie it at either end so it's just a thing in there, or do you take it out?
No, we don't have to do either. The vein stays in.
Okay.
In the old days, vein stripping, that was taking the vein out.
Yeah, taking it out, stripping.
We don't do that anymore. We in all of these devices, it's really kind of cool because all of these devices, in whatever way we're closing the vein down, we close it down. And then the body sort of breaks that vein down since it has now become non-functional. The body breaks it down. And when we look at these veins a year from now, let's say with the ultrasound, all we see is a tiny little fibrotic thread. It's been,
But pretty much, I don't know, maybe somebody just goes in while you're sleeping and does internal maintenance. Just, sweeps up the broken bits. But I still think, and look, that's one thing that I like about Dr. Juleff. You will find when you get a consultant, it broken down into things that you can't understand. There are just myriads of stuff available. I don't want you to just go whooping off to the internet and self-diagnose yourself, but you can sure get a head start there. And then you can pick up the phone or get online and go to veinclinicsofhawaii.com and say, I've had some of these symptoms that the doc and Mike were talking about, and I want to come in. I just want to come in and take a little bit of a look. I think this Clarivain, to me, would have been the great game changer for somebody that was nervous about going in because they remembered when their mom did.
Sure.
This is, you're in and you're out.
Yeah.
Aren't 99% of the procedures you do, somebody walks in, puts on their little gown, gets a treatment, gets a little cookie, and goes home, or wherever they're going back to be.
Yeah, we hand out Kit Kat, not cookies, but definitely. I mean, pretty much all of the procedures we do in less than an hour. The Clarivain, so it uses this mechanical disruption of the internal lining or the inner lining of the vein, and then it also uses a chemical. Mm-hmm. So
that's the next part we're getting to. So obviously, what's happening is if you like to, finish furniture and you're going to restain or paint something, you got to sand it up first. So that's what this hockey stick is, sanding that vein up.
Very close to that. That's a very good analogy. Yes. So we got to finish it off with a lacquer on the inside.
Yeah, let's smooth it out of there.
Yeah. So the device is really kind of cool because it kind of does both of these two things at the same time. So we've got this gun-looking kind of a handle. That's on the outside of the patient, obviously. And that's attached to the catheter that's going into the patient. At the tip of that catheter, we've got our mechanical little wire going around and around. And then at the same time, we're injecting through that same handpiece a sclerosant, a medication that is going to cause basically inflammation inside that vein and cause it to close down. It's the same sclerosant that we use.
I was going to ask if you've heard that term. It's a saline solution of some kind.
Well, it's saline and a chemical. Right. In the old days, we used to use what's called hypertonic saline to close veins down, but now we have a couple of different chemicals, and those are the chemicals that we would use in this setting. And basically, what do those chemicals do? Well, they're just they're doing the same thing that the mechanical part of it's doing, is that it's creating an inflammatory response to the inner lining of that vein, and the inflammation then leads to contraction of the vein, and the vein to sort of collapse, and the opposing walls then stick to each other.
So in some ways, you're actually destroying this thing, but we don't want to use the words destroyed or, forever ripping something out of you. But it seems that It's a 1-2 step, 1-2 punch.
Yeah.
In other words, the wire goes in there and roughs up the area. Then the liquid goes in, and I would imagine has a much better percentage of success if you paint over something without sanding first, it's not going to stick. It's not going to work.
Exactly. That's exactly it. It is a 1-2 punch. And each one of them is making the other one a little more effective in what it ultimately is doing.
Okay, now, what about this catheter that you've put in there to begin with? Does it get removed or does it stay in there?
Yeah, it comes out.
Okay.
So as we're doing those two things, as the wire's going around and as we're injecting medication into the vein, we're slowly pulling the catheter tip back, and eventually the entire catheter comes out. We retract that wire, before we take it out of pull it through the skin, and then that's it.
How fascinating is it for you and your doc friends throughout the venous community? Just sit back in awe sometimes and realize how this stuff has come. I can't believe. First of all, when you think of wire gang, you think of this big spool of wire in the back of a Hawaiian Electric truck. This is a little tiny thing.
Yeah, very tiny.
Is it on a spool? I mean, how do you dispense this stuff?
It's a wire that is attached to the handpiece. Now, within the handpiece is a rotary sort of thing,
Right.
one sort or another, that's making it spin. But the wire basically is going all the way down the length of the catheter, and then we just advance it outside of the tip of the catheter and into the vein, and then it's spinning,
then it's sort of spinning,
and we pull it all the way back, and then when you're done with it, you retract the wire back up into the catheter and pull it out.
And I'm guessing it's spinning the same way it was going in, so that it doesn't, does funny stuff coming out. Let me tell you why I think this is so captivating. What you got to do is you got to go to veinclinicsofhawaii.com, and there's a couple of things in there. First of all, you got to take a look at some of the Living Local videos that are there. And as we progress, some of our shows are going to be there, and tons of pictures. I think it must be very comforting for people that sit down with you, because in our next show, we're going to take care of two additional pieces of equipment. But it must be so that they can be walked through just like we're doing today to our radio listeners. Okay, this is what you have based on our examination of yourself. And you can show me exactly what's going on in my legs. And then this is what we have to treat them. And this is what I recommend. How do you feel about this? And when can we get started? Because isn't that the key? Getting something rolling?
Sure. Yeah, getting people better again. And there are, I guess it's exciting because of the fact that we have so many different things to work with anymore, because each one has its own benefits, and each one is a little better at doing one particular thing in a particular scenario.
Yeah,
or situation.
I'm also going to suggest, as we go through some of these other things, Clarivain is what we're talking about now, but there's also this thing called Varithena, and there's also another term that you're going to learn a little bit later on in the proceedings, and that is the other one. What is it? Venocil. Okay, now when you learn about these things, I'm going to assume that there's no one fix all, even for one patient. That there's might be during the treatment of my condition. This will be deployed in one area, and then something else will be deployed in another. So having the clinic and having the expertise is important, because sometimes I would imagine in the middle of a procedure, you go, you know what, this isn't, we're going to go get me to the so-and-so.
Yeah.
Nurse, give me the thing.
Yeah, because not every job needs a hammer. Needs is a nail.
Yeah.
You need more than just a hammer. But for instance, these non-thermal, non-tumescent devices you mentioned before, entering a vein a pretty fair distance away from where the problem might be. Well, we've talked in the past about venous ulceration and bad skin problems and skin changes and breakdown and all those things that can happen in the lower part of the leg.
I know. I kind of think I know what's coming here, because those conditions are very, very serious, but you're not going up 4 feet to treat them.
Well, we're not. The thing that we don't want to do is have to go through that abnormal skin.
Yeah.
So we don't want to have to start down there and try
Gotcha.
to correct the problem.
Ah, okay.
So
let's go up a little higher and take a look.
Yeah. So one of the advantages, for instance, of Clarivain is to start higher up in the leg. And then, be able to thread that catheter all the way down to where the problem is. Again, we've talked about ulcers and the connecting veins that lead to chronic ulceration. All of that can be treated much more easily with this type of device.
In previous programs, and so we should reiterate just a little bit here. Most of the time, the type of surgeries that are performed by Dr. Juleff and by Vein Clinics of Hawaii, I mean, they can happen anywhere, but isn't it say 90% or higher are from the mid-thigh down? I mean, the varicose veins and the venous conditions that you treat above that pale in comparison to the commonality of it happening lower.
Yeah. Most of the, and again, I think it's probably a pressure problem. But as you go further down the leg, the problems become greater.
Yeah.
But that doesn't mean that the problem isn't up higher. It is often. Often there is a problem with vein function in the thigh. As a matter of fact, most of the time there is. But as you go further down in the leg, the hydrostatic pressure, which is, again, sort of the physiologic problem that we're dealing with, that column of blood that is going in the wrong direction, the lower on the leg that you go, the higher that abnormal pressure state is going to be, and that's what's going to cause the abnormal skin. And
every one of us is trying to adjudicate what is going on here. And that's the advantage of, I'm sure that at this point in your career, there is no venous condition that you haven't seen. I mean, maybe there's something lurking somewhere somehow, but I don't want people to think that every single thing is cookie cutter. But with the array of options that you now have, isn't it that patients that might have been a much bigger challenge a decade ago are not as big a challenge to get a good result?
Oh, absolutely. Yeah, absolutely. Especially with those more advanced states of venous disease, like venous ulceration and chronic skin problems and all of those. Okay,
now, and when we talk about that, in some of these veins that Dr. Juleff and I were talking about before, you're thinking are really long. I do think that people should know how long you can go. Let's say that you have to go way up to the top of somebody's vein and go all the way down. Isn't that sometimes a lot, 2 feet?
Absolutely.
Or more.
Yeah, more because
tall guy longer.
Depends on how tall the guy is. But sometimes it is advantageous to close a vein starting in the groin and going nearly all the way down to the distal part of the calf, the lower part of the calf.
And when we talk about veins and venous conditions, there are some veins that are inside your leg. You cannot see them, but they're the big ones. And isn't it safe also that you don't want to worry people to death about the big ones being a problem, because are they not as problematic? Usually most of the venous work that I've had done haven't been on the deep veins.
Right. Yeah. And luckily.
Yeah, exactly.
Luckily it is that way where, are there people, do we see people with deep vein, venous insufficiency? Oh yeah, all the time. But luckily it's usually limited. And also, most of the time, most problems, as you mentioned, are due to the abnormal function of the superficial venous system, which again is lucky because that's the system we can manipulate. Yeah,
and by the way, it's as easy as getting a really good ultrasound person and a really good piece of equipment. We're going to talk about that, time permitting. Sometimes I know it must be a big hit when a physician or a clinic, or in your case, a series of clinics, has got to make a decision on adapting or starting to employ or use a new piece of equipment, because aren't you on the cutting edge? And that means usually that's where the expensive stuff is.
Yeah.
Because I maybe even people should know that have had in the past an ultrasound treatment, that even ultrasound, the equipment that you're using now is way, way in front of where it was a couple of decades ago.
Oh, yeah. That's, along with all of these devices. Yeah. I mean, ultrasound, you can throw in the same category. The quality of the pictures that we're producing with ultrasound machines anymore is just worlds beyond where it was when we first started, and the machines are actually getting smaller and smaller, just like computers.
Yeah, and gang, that's one of the reasons why I was so glad to have hooked up with Dr. Juleff, because not only is he on with 4 clinics servicing really everybody in the state practically. The interesting thing to me is not just the stuff that's deployable, but the history that goes into it. So I'm guessing that if you've been in practice in any specialty, and most all of you guys are specialists now, right? I mean, your general practitioner has got all of his spurts, all of his experts, and he's going to send them out, and that's where you end up. But I would imagine that even some of the primary care physicians want to visit the Venus guy and say, what kind of stuff are you using? Because they read about all the things that are going on in improving it too, don't they?
Yeah. Well, that's one of the things that we, I guess, probably haven't done as well. We need to educate other practitioners of these newer devices because they're really so much has changed over such a short period of time with venous disease and its treatment that if you went to medical school 20 years ago, you didn't learn about it. Yeah.
But the thing that fascinates me is, I think I've asked you this before, but I mean, I would imagine that even in the ER, you better have the new fast good ones, because that's when you're making some pretty critical decisions, huh?
Oh, yeah.
Is it common to have, maybe just before we run out of time in this show, Doc, maybe you can talk about if somebody does have a DVT and it is in a threatening condition, isn't it really important to get that thing dealt with and surgically fixed quick?
Well, it has to be addressed quickly, yes, absolutely, because a DVT is sometimes fatal, and the amount of people who die from DVT, PE, pulmonary embolism,
sure,
is probably even greater than what we know, because a lot of people die suddenly at home, and we don't get autopsies or whatever. Yeah. But it's a very, very lethal and unfortunately a fairly common problem. But people who have DVT, or if they suspect they might have a DVT, they absolutely have to seek out medical care immediately. Now, what are the two primary symptoms of DVT are swelling and pain.
Yeah, and let me ask you also, I think you said in previous programs, more and more likely it's in one leg rather than both. So the DVT is usually
almost all the time in one leg, not both. And also these are symptoms. We were talking about the fact that in venous insufficiency, the symptoms come on over so slowly over a very, very long period of time.
But that one is different, isn't it?
Oh, yeah. And so, the symptoms of chronic venous problems are easy to ignore, and many people do. But if you have a DVT, it's usually a pretty sudden onset of symptoms, and you have to recognize those and pay attention to them.
Yeah, and by the way, if you've had one, are you susceptible to having more?
You're at a little higher increased risk to develop another one, and it depends on the scenario. I mean, some people there's a difference. We kind of approach the treatment of DVT a little differently, whether or not it was caused by something specific. If somebody takes an 8-hour plane ride and they get home and they have a DVT, well, it's easy to say, oh, well, that was because they were on the plane. But sometimes people develop DVT for no apparent reason, and that puts them into a little more concerning risk level. Our treatment becomes a little more aggressive, and follow-up certainly needs to be much more complete.
There you go, and that's where we're going to leave it this time. However, since you're listening to this one, you need to come back next week, because next week we're going to talk about VenaSeal and Varithena, two more tools in the arsenal of stuff that Doc has. In the meantime, go to VeinClinicsHawaii.com, VeinClinicsHawaii.com, and we'll see you next time. Tell everybody that we're here for you.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, VeinClinicsOfHawaii.com. That's VeinClinicsOfHawaii.com.